So I was just saying, how many wrists have you seen in the clinic in the last 3 months?
3 months?
Yeah.
Did?
You haven't had one visit to you?
No.
Okay.
Probably had maybe 4 or 5 in a year.
Okay, and that's actually not uncommon. Like the guys who do more gymnastics see a lot more of them.
I've seen 2, all of them have been gym.
Yeah, okay. So we're doing a bit more of a push with Gymnastics Victoria at the moment. So with our partnership with them, so we're expecting a few more to come through the gate. So it's a good time to do it anyway. And for you guys, it's a really good start because you're gonna have to. And what I'd like you to do, whether it's together or with someone else, or even if you're together, just for the next few weeks, just go back and do it again because it's one is that it's tricky because there's so much information in a small area, and 2, you don't see a lot of them. So when you get them, you're like, oh god, the acronym comes back again. What's the acronym?
Some other stride positions that they can't handle.
Same one?
Yeah, same one. But I never remember that one.
No.
Yeah.
What's your one?
Same one.
The same one? It's a bit erotic.
They're all right.
Are they?
Acronyms, yeah.
That's
how you remember.
Who to touch and feel. Oh yeah, there's 2. Yeah. the cranial nerves. Remember that?
Oh, yeah.
Did you know what? Who to touch and feel the deal. I mean, I'm on camera here, so. Did you learn that one?
I didn't learn that one.
That was in science before physio, so maybe it was a science thing. So this is just some. The important thing is the other thing with wrist injuries is that it's not like a long bone that has an acute fracture and it's like I physically can't function. A lot of wrist injuries, people can still function even if it's a fracture. A lot of them that turn up are either, people might have an X-ray for something else and they'll say they had a fracture a few years ago and they said, oh, hand swelled up, but I just pushed on. But there is a sequelae to wrist injuries, especially the wrist, that it can be quite catastrophic for someone that you see a bit more later in life. And I don't reckon physios see a lot of those, but we will get to that. If I was to look at the wrist, I would hone in on certain things in terms of injuries that are either chronic or come after some time. And the areas I focus in are on the triquetrum, okay, the scaphoid, the scapholunate ligament, and the growth plate, which is as an adult of the child, especially in the gymnastics population, where we can get some sort of Salter-Harris, different types of fractures, which we'll talk about as well. But this proximal row is sort of the row that cops the most of the load. This row isn't so bad because it's really bunched in and protected, but we're going to palpate all those areas. Okay, so let me just. So this is a really nice picture of what we look at. So if who can be my wrist? Hairy man. Okay. So you've got a bit of Premax on there too. So when I examine the wrist, the first thing we do, like any area, is we just look for any obvious deformity or really sort of antalgic positions that they want to protect it in. And a lot of times, as you guys know, with these type of bones around the wrist, you can have quite a bad injury but not much swelling. Not always. If you're tearing soft tissues, you generally will get swelling. But if you've got bone stress reactions and injuries and impaction type fractures, they don't swell generally. So they'll only be subject to pain in certain areas. So you have to be very mindful that when you do see a wrist and you don't see swelling, it doesn't mean it's bad. It's not bad. It can be really bad still. But if you do see swelling, it's suggestive it's soft tissue as well as whatever else might be going on, or a really bad fracture, distal radius or ulnar, or obviously a fracture in any of the bones. Okay, so I generally look at that, and then I look at general basic movement and get some quick feedback. So wrist extension, wrist flexion, yep. Looking for general range of motion, left versus right, which you do. I'm not a big fan of goniometry. I know we learned that at uni to really micro assess everything. In the real clinic, you might do that once you see a restriction, but as part of your initial assessment, I don't write it down and document every range, not to start with. So I look at ulnar deviation, radial deviation, maybe with a bit of overpressure. If they say, oh, that hurts, you might just do a bit of overpressure for reasons we'll talk a bit about later. Flexion, and then you're in a pronated position, so just to supinate. Just asking again for any problems there at all. And then from there, I'll quickly just go, okay, well, so if you go into wrist extension, then I'll just sort of resist, hold it up, yep, so just stop me moving you, so just sort of blocking wrist extension. flexion, and the same ulnar and radial deviation. I generally do it with the fist. Yep. So go, oh yep, stop me, and then same the other way. Okay. And then obviously a very important one for a number of injuries in the wrist is squeeze, especially scaphoid injuries. If you get a squeeze, so just take it easy, mate. I know you're strong. I know your shoulder. Which shoulder? Yeah, I knew that was just amazing. And then you can also do resisted pronation, and supination. Again, that we check for certain injuries in particular. Okay, so very brief assessment. That's probably the part you should know. Shouldn't have to worry about. And then I'll have a look. Then I'll work my way around the wrist. That's what we want to do now. So, what are the proximal bones? If we start in radial to ulnar, actually get onto each other's wrist now. So
Scaphoid.
you can come in if you want. So
Scaphoid lunate trapsum.
Tricretrum.
yeah,
And then visible.
yeah, which sits at the palm, the palmar aspect, sort of to the triquetrum. Yeah. So what I want you to do. So everyone knows how to locate the snuff box.
Mm-hmm.
Yeah. So you generally ask them. You got a nice. Yeah, that's
Yeah.
a nice looking one there.
Yeah.
Yeah, so I want you to do it on each other. So open the hand up. Yeah, I'll do it on you then, you can all swap, okay? Now, so what you're doing there is you're ulnar deviating. So if you want to get a bit more access to the scaphoid, if you ulnar deviate, it pops out more. Remember, the bones of the wrist are dynamic. That a lot of them don't sit static. So when you ulnar and radial deviate, the actual scaphoid flexes.
Yeah.
Okay, so it flexes. So the tubercle goes rotates, which is why we do what's called a Watson's test. So that's a really nice starting point to fill that. But they actually are quite. So when I palpate, I'll show you. When you're palpating someone for a scaphoid fracture, that's your palpation. It's not much at all, because if you do it hard, it hurts. Yeah, it naturally hurts. Either that or you're not you've got that pain tolerance. Okay, but one thing you do need to do is not just open up the thumb and then feel. You need to flex it, and as the scaphoid rotates and pushes into the finger, does that change? Does it give you the pain? Okay, right. So from there, if we're working over the dorsal aspect of the wrist. If we've got the distal radius. Okay, so we palpate the radial styloid. Okay, so do you know what two tendons go through the radial styloid? Past the radial styloid in a retinaculum.
Adductor pollicis longus.
Yes, tick.
And
Ramon.
I'm kind of
And then
thinking
One of the extensors.
extensor
Color.
radialis.
Yeah, one of those.
Or no?
Abductor pollicis longus.
Extensor
Extensor
pollicis
pollicis brevis.
brevis.
Yep, brevis. Okay. And they together make up the de Quervain's sort of.
Yeah.
Yeah.
Okay.
Okay. So the reason why when we palpate over the radial styloid, it's important is that that's the area where you will get de Quervain's, because there's a sheath there, and the two tendons don't have a lot of room to get through that sheath. And if you're pregnant or then postpartum, when tendons swell, it's just not much room to move. So, and because that tendon is loaded all the time with a newborn, they generally cop it. Okay, so mums cop it. So it is an important one, that group of tendons, especially postpartum, when mum comes in and says, I've got a sore wrist and I don't know why. Okay, so from there, I want you to palpate onto the radius, and then with the radius here, you can palpate a prominence on the radius. If you can just feel over there. Okay, so do you want to just palpate there and feel that? Can you feel that little bit of a prominence there? So let me have a feel of it, and so here's your radius, and then we just come. Yours isn't that obvious, but that's a little, just right there. I want you to feel that, and feel that little prominence. It's called Lister's tubercle. Okay, so extensor pollicis longus sweeps around the tubercle and it heads towards the thumb. Right. I like that as a reference point for one reason. When you slide off Lister's tubercle, you're at the scapholunate ligament or area. So that okay. So you find Lister's tubercle, and scapholunate ligament is very, very important. Okay, for obvious reasons. But that allows you, if you're there, then to know that that's the scaphoid and that's the lunate. Now the lunate flexes, so as you flex the wrist, you should feel it pop out.
Yeah.
Can you feel that?
Yeah.
Okay. Okay, so if we move along from the lunate, if we've got the scaphoid and the lunate, What's next?
The transaction.
Yeah, really important in gymnastics. Not so much in the rest of the population, especially, well, not till you get a bit older. And older I define now as about 60 plus.
Tennis.
And tennis, yeah, racket sports. Racket sports, though, more commonly the ECU is more compromised. And I'll explain why. It's about radial, ulnar variance. I'll explain that a little bit why that would be. But yeah, definitely racket sports can be part of that. But generally, I go more for the ECU with that. But definitely, it's a differential for sure. So now the triquetrum is easy to pulp. Obviously, with a bit of practice, but the triquetrum rotates at a dorsal aspect when you radial deviate the wrist. Okay, you can feel the triquetrum pop out. Can you feel that? Yeah. So it's a really nice reference because that. Oh, you didn't like that one, did you? So basically, once you're on that, then you can move slightly distally to that. And what structure do you run into? What sits underneath the triquetrum? Yeah. So find the bony landmark, and then you slip down at a more proximal aspect, and you're on the TFCC.
Going up this way.
Yeah, going up. Yeah. Yeah. Got it?
Maybe.
Okay, so let me have this and let me swap over. Okay, so yeah, so what I do here is I just do that. Can you just put your finger right there?
Yeah.
Just feel that flex.
Yeah.
Yeah, so that's escape. That's a triquetrum rotating. Yep. Yep, good. So if that's a triquetrum, it means that proximal to that is going to be the scaphe, the TFCC.
Yep.
Okay, which is it'll be in there.
Okay.
Okay, so, and that's really, once you get your handling right and you do get someone like a gymnast coming in saying, I've got pain around here, you can get right on that triquetrum and palpate that and go, okay, if they go, ow, then you might be suspicious of an abutment syndrome where the bone's actually got some stress through it. And Ray's actually a really good one to feel because you're quite hypermobile on your wrist. I can feel there's quite a bit of mobility. That's a very nice triquetrum to mobilise. So that's the proximal row, which is probably the row that I actually, in terms of the trapezium, trapezoid, capitate, hamate's important too, but only in a selective group of people. But it's the proximal row are the ones that we're really looking at, generally most of the time. Okay, so swap. Now I want you to palpate. Mate.
Okay. What's this all the?
Now don't be deceived, mate. I know I'm a bit older, but I've been told my hands are like a 21-year-old.
Oh. This. Let's just go forward.
Yep, so important, yeah. Palpation, one thing I find when you are sort of new, and you're okay, but some people really push too hard. You don't need, I call it be the delicate genius, you know, sometimes I push too hard. What shows that from the delicate genius, does anyone know? Seinfeld. Alright, so have you come off Lister's tubercle?
Yeah, I think that's it there.
Yep, so here we've got extensor pollicis longus, so we've got a good look at all the tendons there.
That's the tubercles there. So we can look at that way. Yeah. That's my unit.
So let's go for it then, right?
Yep, so just, I reckon you probably, yeah, that's it, yep. Because I've got such big muscles around my wrist, it's hard to feel.
It's hard to get it one, isn't it?
Click.
What's that, Skip? What's that?
Oh, the wrist is a bit like the shoulder. It does click a bit.
Yeah.
I mean, there's lots of different bones in there. So just make sure that you're on the
TFCC.
Yeah, you're doing more special tests. That's next. But if I radial deviate, if you you should be able to feel my triquetrum flex. Yeah, which gives you a nice reference point that down below that or proximal tarda is where the TFCC sits.
Yeah.
If someone's got an acute injury, that'd be just sort of globally around.
It's hard to, if they're reporting, there is a couple of special tests to differentiate, which I'll take you through in a sec. But yeah, if you've got pain locally there, your differentials are ECU, stress fracture, TFCC. Nuts and bolts. That's what it is.
So what would you, if you couldn't decide
Yep.
your special test, what would you scan? Would you go straight for an MRI or?
Let's get to it, mate.
Jump the gun.
I'm loving your enthusiasm. I'm going to get to it. Because it's, yeah. Okay, so are you comfortable with those sort of landmarks?
Yeah.
If you had swelling over the, if someone reported a fush and had swelling around this part of the wrist, here, what, just a little localized swelling, what would a real important differential be? Yep. Scaphoid fractures themselves rarely give you swelling. They just don't. But scapholunate tears do. And the bigger they are, the more swelling you get. You get a grade 1, there'll be a little bit of a puff of swelling, and then 2s and 3s blow right up. And they get a bit of bleeding as well. Because once you tear the ligament that much, you tear capsule, and if you tear capsule, you're tearing, there's blood involved. So you'll get a small bleed as well. Okay, so dorsal aspects, scaphoid palpation through the snuff box. We talked about the radial styloid, so abductor pollicis longus, extensor pollicis brevis. Lister's tubercle, adductor pollicis longus sweeps around there, but it's also the reference sliding distally into the scapholunate joint, and obviously the ligament that sits above that, that's important, which we'll talk a bit about later. Then from there, you go on to the triquetrum, okay, so lunate to triquetrum, which you can palpate because it rotates with radial deviation, and then from there, distally, you can palpate into the TFCC. One other test I didn't talk about was the Shuck test, which is effectively the distal radial ulnar joint. Yeah, piano key sign's another name, or Shuck test. The test is this to see how unstable it is, left versus right, but you can also get the piano key sign where the ulnar, because the radius is heavier anyway, the ulnar just sits up. So it looks like, and in left versus right, it looks quite abnormal, one in some people. Carly Harris, hi Carly, one of our physios, she has abnormally hypermobile joints throughout her body. She has a piano, it's a false positive. She has them on both sides, they sit really obvious and abrupt. So if you want to have a look at one that you'd seen abnormal, look at Carly's normal. Yeah, so it's quite obvious. The other thing too, just again with children, is about an inch, a centimetre to an inch, so 1 to 2 centimetres proximal. You're on the growth plate, the apophyses, so the epiphyses I should say. So you need to palpate around there in children to see is it sore in there, because that's a real important injury if they have Salter-Harris 1, which is widening of the area, which needs to be splintered for 6 weeks. Okay, and I'll talk. That's one of my slides. That's next week's discussion. Right. The other things that we look at here are which you know. Extensor carpi radialis longus and brevis into the 2nd and 3rd mets, and extensor carpi ulnaris as well, which is inserts into the 5th met here, and they're sort of the more important tendons on the dorsal aspect of the wrist. Okay, Palmar. Right. So Palmar, the only key landmark, generally things we look for, because there's not much here in the wrist, but in terms of palpation, is your pisiform. Okay, so do you remember what tendon runs through the pisiform?
I'm going to say that it's like a digitomegaly
No.
tendon.
No.
No, it's something important to remember. It's-
Flexor carpi ulnar.
Yeah, flexor carpi ulnaris. Yeah. So it's important. Yeah, the pisiform is it works through that, even to the hamate as well. Okay, so so that's important. And the other thing, so what sits distal to the the hamate. What's the important part of the hamate? The hook. Yeah. What does the pisiform and the hook of the hamate make up collectively? Do you know what canal it's called? Guyon's canal. Yeah. So if you hurt the pisiform with a fush or an overload of the ECU, FCU, what sort of fracture would you get of the? Yeah, can you get it? So you can get a true fracture line through it, or a comminuted fracture. Sometimes you get X-ray or get a scan and you can see they're actually born with a bipartite. Bipartite, so it's actually born with 2 parts. And they become tricky when you're dealing with a gymnast who has pain through overload of that, or is it an actual fracture?
If you get one of those fractures, would you be likely to see ulnar nerve symptoms as well?
You can get that as well, yeah, for sure.
Yeah.
Not always, but you can. Yeah. When you will get more ulnar nerve syndrome symptoms is when you actually fracture your hook of hamate,
Right.
because the bleeding goes into the canal and it's toxic to the ulnar nerve, and you'll get more fourth and fifth digit signs. So the hook of hamate, it is a little tricky, but you can actually palpate it.
It's quite tender, isn't it? I remember.
Yeah, it's not
Yeah.
nice to touch.
Yeah.
So it's there. Now, if I give that a good push, does that? I mean, you are tough. I know. Yeah.
I think you're up in there.
Yeah, I think I'm on it actually. So just relax for me. So that's pisiform, and then you draw a line. It's about another centimetre, a line from the pisiform towards the index finger. So if we go there, about an inch, it's it there. Trust me.
They are a bit tender, aren't they?
Yeah, that's it there. So push harder. You just got good. That's it. That's it there. Give me yours. Okay, so Ray's starting to sweat. So there's So there's your pisiform. I'm going to be easily able to feel yours. Just come this way. That's it there. Yeah, right there. So you're going to go deep, but it is quite. If you look here at the if we go back to the bones. I mean, it's not the best angle. We don't have a wrist here. It does stick out quite a bit.
It does.
Yeah, so that there and there connect up, so the ulnar nerve heads through there, and that's why when that fractures, it just bleeds into the canal. So if you have a hook of hamate fracture, which is mainly on a fush, again, they'll get real ulnar nerve signs, and that has to be scanned because it has a it's a what is it that what's it called? I can't remember the brain fade. With the blood supply like the scaphoid.
Necrosis.
Yes, so you get AVM. Yeah, my fault. So you get an AVM of the bone, which means it has to be splintered for 4 to 6 weeks.
Yeah.
Yeah, you have to treat it. Something small and you think not really that important, actually is important.
Yeah.
You don't want to get AVM, you get nerve signs, you have to have it debrided, it's a nightmare. So, yeah, okay. Yeah, now we got to the good stuff. Okay, so scaphoid fracture. How do when do we see these?
Pushes.
Mainly foosh, yeah. A lot of them turn up to the clinic 6 weeks after, saying I hurt my wrist because it bloody hurts, but they generally can still function.
Yeah.
And they turn up weeks later and they go, I had wrist pain for a number of weeks. I'm even having my kids' football team. The dad will say to me 3 weeks later, he's training me, his wrist has been sore since he landed on a funny 3 weeks ago. I said, well, can I have a look at it? And I'll test, I go, I think he's got a scaphoid fracture. So people think it's okay, and parents generally think for children that they're okay, they just have to push through it. Because there's no obvious, as I said, there's no obvious deformity.
There's a kid do you remember the kid from Park Orchards that I had? He
No.
was pushed through 3 months of playing with wrist pain.
3 months, yeah.
3 months, and just said whenever he'd spoil, he'd get pain in the wrist.
Yeah.
And he ended up having that complete fracture through the scaphoid and needed surgery.
Yeah, so you don't want to, if you have to get to the point of bone, sort of having to put bone grafts in, it's a rule. It's not great, and they're out for a long
Did
time.
you just send him a plain X-ray?
Huh?
Did you send him a plain X-ray?
So let's talk about how you diagnose these, right? So obviously there's the history. So the fush, pain with certain things like extension, trying to pick up a kettle. So certain things go, yeah, and they generally point, it's just in here somewhere. It's quite vague. They don't suddenly just say it's in the snuff box. They go, it's just around here anywhere.
Yeah.
Did you have any swelling? No, I didn't see any noticeable swelling. Nothing over here, because you want to differentiate a scapholunate.
Yeah.
They go, no, but sort of just a fall, no bleeding, no swelling. I just had pain around here and it hasn't gone away. So the first thing is that generally, and it's not too hard, the snuff box palpation. First thing, do you feel pain there? Refer to the other side because it is tender. That's the first thing. The second thing is you can go to the dorsal. Actually, I didn't mention this before about dorsal palpation, but there is a scaphoid tubercle as well. Not as commonly fractured, but you can fracture that. But generally, it's more snuff box as your first line of assessment.
Yeah.
So that's the palpation. The second thing is some general tests. So first one is wrist extension. So these are the ones that really give you the idea that sort of giveaways that it's likely to be a scaphoid. Wrist extension. If they report no pain with that, it's because they're not going into pain. So you need to make sure you overpressure, and they'll go, that's giving me that, that's causing some problems where I feel the pain. The second one, which is really important, is the pronation test. So they won't like that. So that's the second one. They're just not going to like that. Same thing. It's around here somewhere.
And the third one, which is really, really obvious, is the grip. So grip strength, go, 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 go. They either, and really important is they're not reporting direct local pain here. If they keep pointing to this area, you're going to be suspicious of a scaphoid
Yeah.
because they can give a mixed sort of presentation. They can be similar. But the grip sign is really important, and they'll either not grip strong, so they won't reproduce pain because they're just weak. They won't. So you do your left and right together, and you go, mate, you're going to give me more than that. And they either say, I just can't, because they've just inhibited that much, or they do, they're tough enough to do it, but they'll report pain. Yeah. Okay. So now, and that's really the tough history of FUSH. Pain with certain tasks, lifting things up, pushing up from a chair. That's a really important one. Pain around here, and those tests are positive. Then you have to exclude a scaphoid fracture.
Yeah.
Which means what? Because how do we formally diagnose a scaphoid fracture? Imaging. In this day and age, we've got to image. So what's the suitable image for this?
You need different views, don't you, for a scaphoid?
You just write query.
You need different views for a scaphoid fracture.
Yeah, they'll do that for you. You have to query whatever scan you're querying. This is sort of separate to today's specific wrist. The last thing you need to write, if you write wrist injury for an X-ray, you need to go back to uni. You need to give the radiologist as much information as possible. And I've seen this, like, they hate it when someone writes hand injury. Like, it means you don't know what you're doing. So you really have to write give the radiologist almost like a full summary. History of FUSH, query scaphoid fracture, appropriate views, X-ray, plain film. And they'll do the views, yeah. But you're right, they do need to get to certain views.
Yeah.
So should everyone get an X-ray who has a scaphoid?
What do you mean, as a first point of imaging?
Yeah.
If you, depends if they're.
Do you mean if
I
they're
would.
positive? Like if your tests are positive, should they get an X-ray? Is that what you're asking?
Yep.
Or yes?
Yep.
Because you want to know how bad it is.
Yep.
And whether they're going to need surgery or just splint.
Okay. So the answer is yes, but then there is a caveat to that. So if they present to me 6 weeks after the injury, I'm going to quickly set them up for a plain film because I'm going to see a lot. Why? If they've got a scaphoid fracture, it's likely I'm going to see enough at 6 weeks after. Why?
Because they don't heal very well. I don't know.
Any ideas?
Zero at the end there.
You know what an occult fracture is?
Oh, what's the
An occult fracture? OCCULT?
No.
Okay, so it's with more of these 3D looking bones, like a scaphoid, where initially they don't present on plain film.
Yeah, because you don't see them until like a week after or something, don't you?
Maybe longer, that's why I said, that's why I'm trying to make you think.
Yeah.
At 6 weeks after, FUSH, all your signs are positive, race them up for a plain film, right? It's likely you're going to see the scaphoid, you're going to see sclerotic bone, you're going to see healing, you're going to see stuff that you're not going to see early on, right? What if they've done it the day before?
Well, if you send it for an X-ray, you might not see it anyway, but then you split them and then send them like 2 weeks later and double check it. Would you send it for a repeat X-ray? Or would you go MRI?
It's a really interesting one, right? If you've got enough skill and trust in yourself, then you could just do what you said. I'm going to send you for a plain film because you've got enough pain, I need to exclude everything. I want to make sure you haven't got a CMC joint fracture, an avulsion plus, because it may not be a scaphoid. The FUSH can give up lots of stuff. So it is good management to exclude differentials in the plain film. The question is though, is that if you're so hell bent on it being a scaphoid fracture, you're probably not going to see anything on the X-ray.
Yeah.
But you might want to know, you might really want to make sure, but as a clinician, like, I suppose like me, that's aggressive with my imaging, you might want to know more. Am I making sense?
Yeah.
If the X-ray doesn't give me the information I need at day 1, but it gives me the information at day 6, but I'm at day 1, or week 6, but I'm at day 1, and I want to make sure I'm assessing, managing this patient appropriately, I'm probably going to put them in a splint, and about a day, I'm going to set them up for a plain film to exclude whatever else there may be, and I'm going to check them about 2 days later, and I'm probably going to suggest at that time, if I've still got all those signs, to get another scan.
If you fracture your scaphoid and you send it for plain imaging and nothing comes back on X-ray but you still suspect that it's probably there,
Yep.
would you suspect that if it was bad enough that the fracture needed surgery, that you would actually see that on an X-ray one day post because it would just be like completely like
No, because
no?
you can have a subtle fracture of the scaphoid. That's not because of the risk of AVN. So there's one-way blood supply.
Yeah.
It's probably going to die anyway if it's still being loaded and loaded and loaded,
Yeah.
and the blood supply can't get through the waist to the other end of the bone. Yeah. So, but this is a really good discussion because you could probably go to 20 different sports med clinics and they're all going to treat it a little bit differently.
Mm-hmm.
The thing is that if you miss it, right, if you plain film them, put them in a back slab or whatever you might splint, right, and they go, and the X-ray's clear, you say, I'll see you in a couple of days. Sometimes those people don't come back. They go, oh, the X-ray didn't show anything. Yeah, so I'm very informative of someone when they come and see me, and I go, right, scaphoid fractures don't always come up on X-ray, but that's a standard protocol for us to check because it could be a fracture of something else.
Yeah.
But I want to check just to see if it's a real bad one. I know what you're saying.
Yeah.
So it is tricky because with those acute ones, if I'm suspicious that there's a scaphoid fracture, they get an MRI.
Okay.
Okay.
Would you get MRI as first protocol for you?
Yeah. So historically, and I think, I don't know if we had this discussion, is that if you go back to the notes here, right, so we've looked at, these are all the tests, okay, we did. If we look at the appropriate, see, a CULT, so you look up, you'll get these notes, right, so a CULT fracture, means you probably have to repeat X-ray.
Yeah.
But if you suspect it, you can initially do a bone scan or an MRI. Now, this talk was written a few years ago, and I haven't changed that. So now I would generally say to someone, look, bone scan is radiation, and bone scan looks at osteoblastic versus osteoclastic activity. That's what it's looking for.
Yeah.
So if osteoblasts are really rampant, you're going to get a hotspot. So that's look at a bone activity. An MRI looks at water,
Yeah.
looks at effusion. So an MRI 7-8 years ago on a 1.5 T scanner, so not as high end scanner, may not pick up a subtle fracture on a scaphoid. Now they pick them up. So you say to someone, I can send you for bone scan, which means you have to have dye in the morning, come back in the afternoon to have the scan, you've got radiation through you. If MRI can give you a similar outcome, you'd probably MRI because there's no radiation. Yeah, it's more convenient, and that's probably the modality of
What's
choice.
the price difference between a bone scan and an MRI?
Well, now because our doctors can rebate them, they're about the same now.
Okay. Yeah.
The other question which is important, thinking about scanning, which is what you want to build in the first couple of years, what should I choose and when? When would you CT this person as a first port of call?
I don't know.
I just go straight to the MRI
Why would you?
because it will investigate other things as well.
Yep. So
Ligaments.
yep. So the MRI, CT is bone, just bone.
Okay.
And disc in your lumbar spine, but in these areas, it's generally looking at bone.
Right.
The problem is that this is where it's again working out what you need to do and when is it. If you've got a very subtle stress reaction in the scaphoid, which still needs to be looked after, a CT scan probably won't pick that up. So a CT scan picks up fractures. So if you have a bone stress, it's unlikely. If a doctor saw a lot of fluid on a scaphoid on the scan, or say navicular, if they saw a lot of fluid on an MR, suspicious of a stress fracture, they would then CT it because they want to grade it
Yep.
and know how bad is this fracture. It's like lumbar spine for a pars. If you get a pars and you've got fluid on the pars intra-articularis, the doctor will probably scan that to say, is it a full complete fracture? Is it a partial fracture? Because if it's partial with the back brace, it's likely to heal. A full fracture is less likely to heal.
Mm-hmm.
So it dictates your management. So sometimes CT is appropriate once so it's tricky, like you have an X-ray and then you have an MRI, and then if there's enough fluid in the MRI of the scaphoid, then it's probably best practice then for the doctor to CT that to grade the scaphoid fracture. Because if it's in the waist and it's complete, it's a complete fracture line, then they probably need a screw.
Yeah.
So that the blood flow can get through.
Yeah.
If you let them just continue, and it's a complete fracture through it, which you won't pick up always on MRI, but definitely will on CT. If it's not a complete fracture, you probably get away without screw. It's hard. It's all these things you got to think of, and we haven't even gone past one bone yet. Okay, so anyway, skate forward. So we've got a fracture, right? So we have a MRI. We've got a skate forward fracture. You probably get the doctor involved. What's the management?
Splinting for 6 weeks or surgery.
Yeah, splinting for 6 weeks or surgery. Yeah. Sometimes I like to, if it's borderline, I might repeat it after 3 weeks and see if it's healing, because there's the chance of AVN, and then I might get a screw secondary. If you're a physio and you fracture your scaphoid, you're just going to get screwed, because you're going to start working about 3 weeks later.
Yeah, okay.
So it's just a choice. I mean, it's a bit more aggressive and it's surgery and a general, but it means you can work.
Yeah.
Would they ever do that in your local?
No, well, not that I know of. But for you, your Irish dances are unbelievable.
Let me watch.
Okay. So scapholinated dissociation, scapholinated tear.
Yeah.
What do you guys know about those sort of things? Do you learn much at uni?
A little bit.
Okay. How much time? What time is it?
I tend to.
Who has the patient at 2?
Yeah, I do.
Okay. That's all right. Well, you might be 5 minutes late to that, but that's all right. Well, I just want to get through 2 more important areas and then run off. Okay. So, So, what's the mechanism of the scapholina?
It can be a push as well.
Yeah. It is a push. One fails with the other, or you can get mixed. You can get a scaphoid fracture and the scapholina ligament. How do you palpate the scapholina ligament? What tubercle do you come off? Lister's tubercle. Yep. So slide off that. It's just an easy reference point to know where you're going. Okay. So someone presents to the clinic. They come in 2 weeks after. 2 weeks. Said, I fell on the weekend. I was kicking the footy with my kids, and I'm struggling to screw. I'm a tradesman. I'm struggling. What are your questions?
Clicky.
Yep. Clicky is important. Yep. What else? What do you want to assessment? So we. Yep. Swelling. So 2 weeks. So you see any swelling? You go, yeah. You might say.
To be gone by now.
Yeah. So it can go pretty quickly. If it's a grade 2 to 3, it's likely it maybe not, but he'll say, yeah, I had a bit of swelling here.
Yeah.
It's bizarre. It was like just a local area. Okay. So straight away you're going, fush, local swelling. Okay, I need to consider that, but you could have broken a met. You don't know yet. So that's where you start to do specific palpation. So swelling, and then he just describes, what's he going to describe in terms of movements?
Extension.
Yeah, probably overpressure, not always with the grade 1. They, if it's a small grade 1, they don't always complain of pain until you like a push up. They need to do a push up for grade 1 to really test it. But anyway, when I palpate, I'll show you what I do. So obviously you come off Lister's tubercle into the joint, okay, and you basically, if you flex the wrist, it becomes more prominent, and you really just push around that area. Is that? I'll say, oh, that's the sort of spot. That's where I feel it. But you've really found it. So you're like straight away, you're like, okay, I'm on the hot spot here. Now, from there, because they had a lot of swelling initially, say 2 weeks earlier, you do just need to have a very gentle palpation through the mets, okay, just to make sure. Now, occasionally I'll see so if I come off the, I should have gone through this with you too. If I come off the CMC, what's the first bone there that makes up the carpometacarpal joint?
Trapezium.
Yes, okay. So that can fracture with a thumb fracture. So you just need to palpate. And then what's the one next to it?
Trapezoid.
Good girl. And then from there, the big one up, capitate. Let it go. She's
read up.
She read up.
Yeah.
Eh?
Prepared.
Okay, so trapezium thumb fracture is common. Trapezoid uncommon. I've seen it stress fractured before, but it sits in this little line. It's protected in concrete. It's very hard to damage that. And then you got capitate, which can fracture as well. Not as common because again, while it's very large, it generally doesn't get. It's protected. But you still need to palpate all these bones to make sure you don't have a differential of a fracture because you reported swelling. Okay. Okay. So we go back to there, and then we go right. Fush, a little bit of swelling, pain on the scapholina ligament. Okay. What other tests can I do? Which is a test for the scapholina ligament. Watson's. Yep. Which takes a bit of practice to do.
And there are a lot of false positives too, so you really have to be good at this.
And check rate side.
Yeah, so I'll show you how to do it, and then you guys can have a go on each other. So basically, so what happens is that when your wrist goes from ulnar deviation to radial deviation, and again, this is about wrist bones being dynamic, the scaphoid flexes. So the scaphoid rotates that way. So as I do that, and the reason it rotates is that ligament, it's stiff. So as you move, because this locks up here, that scaphoid bone, because the ligament's tight, the scaphoid has to go somewhere and it rotates anteriorly. If that ligament's gone, right, and you're doing that, there's less chance it's going to want to rotate. Or you can block it because that ligament's ruptured and it sits static.
Oh, okay.
Yeah, it sits static because the ligament isn't winding up to allow the bone to move because it's ruptured, it's flopped. Because if these ligaments, think about the bones of the wrist under pressure all the time, okay? And that's why, have you heard of a visi and a dizzy?
Yes.
I'll teach you more about that next time. A dizzy is based on a scapholunate injury. Once you rupture that scapholunate ligament, you get a dizzy, right? Now the dizzy is the lunate, which is a lunar bone. Once that ligament pops, the lunate goes poof. It loses its form. So these bones are under constant tension in a certain framework that they are allowed to be in because of the ligament structures. As soon as that scapholunate ligament pops, the lunate lives in a different place. It moves, it shoots up, and that's where it stays.
Yeah.
And that's bad because the wrist deteriorates from that very quickly over the next 3 to 4 years if you don't do anything about it. So come back again. So what happens? That's the scaphotubical there. Okay, so it's quite obvious on you. So what happens if what we do is we go from slight extension, 10 degrees wrist extension, ulnar deviation, and we put our thumb on the scaphotubical, and we go into radial deviation and slight flexion. Now what happens with that is that, and I can feel it, that tubicle is rotating nicely.
Yeah.
Okay. In someone with scapholunate dissociation, as you do that, because the scapholunate ligament's gone, you won't flex, and when I let go of this, you hear a clunk, pop. Now, this isn't the way the test was described, but this is the best way to test this. You think of it like a subluxing joint. If in that position the scaphoid should be rotated, all I do with these, this is my quick way of doing it, I just put them in radial deviation flexion and I just sublux it in and out. I can feel it subluxing, I go off. It's really weird. It's like you just feel it clunking. Now on Carly, she does it naturally. So she's a really good one to feel because what her normal is a positive for scapholunate ligament.
Yeah.
Okay, that makes sense?
Yeah.
So slight extension on deviation, on the scaphoid, on the tubicle, flex, it shouldn't rotate, so when you let go, it pops. Okay? It clunks.
Yeah.
Have a go. You can do me. Does she?
Okay.
How you going, Alison? The hour of power? I think Alison might get an Academy Award for her work today. Yeah, clunk. Yeah, so that's called old man clunk. Yeah, so that's the scapholunate. Yeah, but that's, remember, you have to compare that with the other side. So I've got a clunky one. Go this way, you got to give me more radial deviation. Yeah. You're on the tube.
It's luck.
Yeah. So more clunk on the other one?
More clunk in the other. So if you
So-
were trying to hunt around for it, you would.
I generally put them in radial deviation there and now sublux it in and out. Yeah. There you go. You'll get a normal clunk, but
and
what
that'll clunk.
what you're also looking for is reproducible pain. That test, there's two measures. One is pain and one is clunk.
Mm-hmm.
You do want them to feel pain there.
Yeah.
Do me one more time that side. He's getting a really good clunk out of me. He's very happy with himself. My power is I've just removed the clunk. Sublux it now. Oh, sorry. I'm very relaxed all now.
There you go.
just remember the wrist does clunk.
Mm.
You're just going to marry it up with symptoms and what the clunk you're feeling isn't. You're feeling a click. What happens with scapholunate dissociation? You have a little go.
Yeah.
Is it's a subluxing clunk.
It's a big
Yeah.
movement.
It's a big movement. See if you can get the clunk. He's really happy with the clunk. What I want you to do, I want you to more, I feel like you're more gripping me, right?
Yeah.
More than pushing that nicely that way. If that makes sense?
Yeah.
It should be a clunk. I think you're clicking more than me.
Yeah, no clunk.
No clunk.
No,
No clunk.
skills.
Okay, so we've got the situation. We're suspicious of the mechanism.
Yeah.
We're suspicious of further history and general range of motion,
Mhm.
and we're suspicious of palpation.
Yeah.
Okay, what do we do next?
Rule out everything else.
Yep. What imaging are we going to use?
Well,
MRI.
you could use a plain film if it's like if you suspect a dislocation, like it'll sit
Subluxation of the
differently-
joint.
Yeah, it'll sit differently on the plain film than you would normally expect.
It's a really tricky one, to be honest, because I would still plain film them,
Yeah.
and I would ask for the Terry Thomas sign, which is effectively a grip test, left versus right. If they have very subtle symptoms, it's a tough one because a grade 1 you don't do much about. You just generally, you can give it a splint for a couple of weeks. Grade 2s need more proper splinting, and grade 3s need surgery, right?
Can you grade it from a plain film?
No, you'd have to scan it.
So why wouldn't you just go straight to an MRI if you're going to get a scan, like a plain film, and then you're going to scan them for an MRI anyway?
It's a really good question.
Grade it.
It's a really good question, and because MRIs are so easy now to get, they're everywhere, rather than 10 years ago when there was only about 10 in Melbourne. If I'm suspicious that there's some sort of level of scapholunate dissociation, 1, 2 or 3, I'm probably going to scan it.
Okay.
Because I know the sequelae can be so bad, which is effectively what's called a slack wrist. So if I talk about that dizzy, which we'll go through next time.
Yeah.
Dizzy, the sequelae is bad if they're not managed. So you probably do want to scan them. But look, to be honest with you, I'm pretty experienced in this area. If I knew it was a grade 1, I wouldn't worry about it. But if I'm not sure, I'm either going to refer him to the doc, or I'm going to do a bit more aggressive scanning. Yeah. If they present to you 6 weeks after the injury and you're suspicious, scan for sure. Do you know what I mean? Because it's chronic then.
Yeah.
You need to validate it. They've got pain for 6 weeks. A grade 2 has to be excluded. You need more information.
Mm-hmm.
If they turn up 2 days after and it's not much, and you're like, it's in the area but it's not much,
Yep.
I could scan it, but it looks so negligible. I'm just going to watch it for a week. That makes sense?
Would you
Yeah.
just tell them to like rest, or would you go like taping, splinting?
I put him in a splint for a week,
Right.
and probably just if I was in a hurry, I'd just give him off the counter splint. So look, a week in this, I'll see you next week.
Yeah.
I want to make sure, blah blah blah, blah, and just check them out. Yeah. Okay. What time is it? You gotta go.
Yeah, yeah.
Okay, that's good. So they're the 2 ones that take the most time. So next, are we on for next week?
Mm-hmm.
6 weeks to
What does that?
fresh tissue.
Oh, sorry. Yeah. So yeah, grade 1 to 2 is 3 to 6 weeks.
Yeah.
6 for grade 2.
So you wouldn't wait too long in a wrist splint because of that last point.
If it's a grade 3.
Yeah.
If they need surgery,
How successful are those?
really
Surgery?
successful. If they tie up the native ligament, that's much better than waiting and having to get grafts from Palmaris or whatever else they.
Yeah.
And here's just a really nice look at the test. Is that again here, see the dynamic as you go from ulnar deviation to radial.
Mm-hmm.
Can you see how normally that's trying to flex? That scaphoid's trying to flex.
Yeah.
If they have a ruptured scapholunate ligament, that won't happen. That will stay as it is. That doesn't allow to flex.
Yeah.
Okay. So that's the problem.
Mm-hmm.
But that means that as you get to radial deviation and that hasn't flexed, as you let go, it pops because it does pop then.
Mm.
It pop, and you get more of a clunk than one was more of a click. Okay. So,
Mm-hmm.
all right.
Thanks, Paul.